Begins part 2 of the fluid and electrolyte acid-base lecture. I'm going to pick back up with chloride, another one of our key electrolytes. This is usually bound to sodium, and when you add sodium and chloride, you get saline. The role of chloride is it helps maintain fluid balance. It also plays a role in acid-base balance, and we normally lose chloride in our urine, sweat, and stomach secretions. If we have hypochloremia, signs and symptoms will include, if it involves chloride as well as water loss, you'll have signs of dehydration, most likely related to vomiting or diarrhea. Could be related to renal failure as well, and again with the renal failure we've diluted the chloride, so our levels will be lower. We lose chloride with burns and also with loop diuretic use, and again loop diuretics are your Lasix, your Bumex, and your Demodex. Treatment of hypochloremia will include IV of normal saline, and then treating the underlying cause, fix whatever's causing the problem. With hyperchloremia, signs and symptoms, if water is gained as well, is you'll get hypertension or increased volume. You'll have increased heart rate, may develop congestive heart failure or pulmonary edema. Hyperchloremia is usually related to renal failure as well. Could be diabetes insipidus, not to be confused with diabetes mellitus. That is a different condition altogether. And we'll study diabetes insipidus a little bit later in the curriculum. But it essentially is when you have or you have lost the ability to hold on to volume. You drink, but then you're turning around and losing it as well. Also, decreased water intake can cause hyperchloremia. Treatment for hyperchloremia involves hydrating the patient and again treating the underlying cause. Lastly, let's talk about phosphorus. Phosphorus is also referred to as phosphate. Phosphorus is the one that's friends with calcium in the bone, but outside the bone they are opposites, so in the bloodstream they'll go opposite directions. It too is regulated by the parathyroid hormones. And the roles, it strengthens your bone and teeth and helps with the development. We also need phosphorus for nerve and muscle function, and it helps maintain our acid-base balance as well. With hypophosphatemia, signs and symptoms may include muscle weakness, muscle dysfunction, altered mental status, and a decreased cardiac output. Most of the time when we see low phosphorus levels, it's due to malnourishment or alcoholism. Same thing with low mag levels. When magnesium is low, it very well may be related to malnourishment or alcoholism. Maybe the patient has phosphaturia, and what that means is they are losing lots and lots of phosphorus in their urine. So if they lose it in their urine, they're not going to have it in their serum or in their blood. Treatment, increase their dietary intake of phosphorus. It may be oral, or we may have to give them IV supplements such as sodium or potassium phosphate that will increase their phosphorus levels. With hyperphosphatemia, this is the more rare of the two, and we see it commonly in patients with renal failure. Signs and symptoms may include hyperparathyroidism, or if their parathyroid gland is overly active. We may also see calcium deposits form as well. Keep in mind, calcium and phosphorus go opposite. So if there's increased phosphorus in the blood, well then the calcium is going to be trying to move out of the blood, and we might see calcium deposits in interesting places. Hyperphosphatemia is due to decreased excretion in the urine, and the number one culprit is going to be renal failure. You normally do lose phosphorus in the urine, and of course if your kidneys aren't working, it would make sense that you would have higher levels. A decreased parathyroid hormone also, or the PTH, will also cause some hyperphosphatemia, but we'll study the endocrine system in more detail next semester. The treatment for hyperphosphatemia includes phosphate binders. One of the more common is a drug called Phoslo, and it does just what it sounds like it would do. It lowers your phosphorus level. Also, we'd want to restrict or limit the intake of phosphorus in patients who have hyperphosphatemia. Next, we're going to talk about acid-base imbalance. First of all, let's define what pH is. pH is actually the partial pressure of hydrogen ions in the body. When we're talking about pH, we're referring to a 1 to 14 scale, with 1 being very acidic and 14 being very alkalotic or basic. 7 is considered a neutral pH. If you consider what the normal blood pH is, the normal range is 7.35 to 7.45. So on the 1 to 14 scale, our body is actually alkalotic or more alkaline than it is acidic. Some things you need to keep in mind when learning about acid-base, because this can get complicated. Acids release hydrogen ions into a solution, so they let go of them. Therefore, acids have a lower number of hydrogen ions. So when you're thinking about something that is acidic, or something that has a pH of 1 to 6.9, which we call acidosis, it's because they've released those hydrogen ions, or they let go of them. Bases, on the other hand, hold on to hydrogen ions. Therefore, they have a higher concentration of hydrogen ions. So anything with a pH greater than 7.1 to 14 will be considered alkalotic, or what we commonly call basic. Your pH is regulated by buffers, lungs, and kidneys. So we've got 3 different systems that are working in the body to help regulate your pH and make adjustments, because we want our normal body pH to be 7.35 to 7.45. We're going to first talk about buffers. Buffers travel throughout the body like little bitty sponges, and they go soak up hydrogen ions as needed, or they might let go of hydrogen ions as needed. So they're there in the body to help regulate whatever imbalance is going on. They can take or give, again, depending on what's needed to maintain our pH balance. The nice thing about buffers is that it occurs within seconds. Buffers can act immediately. If the patient has acidosis, meaning their pH is acidic, the buffers will bind with the hydrogen to increase the pH. So we're going to hold on to more hydrogen ions and cause our pH to elevate. If the patient is alkalotic, or they have too many hydrogen ions, then the buffers are going to release those ions to lower the pH levels. Your lungs are the second mechanism that we use to compensate, and the way they function is by manipulating your CO2, or your carbon dioxide. Your body needs are detected by the respiratory center in the brain, and we can adjust how fast we breathe and how deep we breathe within minutes to compensate for a pH imbalance. If the patient has acidosis, our body will actually increase the rate and the depth of our respirations to blow off our CO2. And something that always helps me remember the lungs is I consider CO2, or carbon dioxide, an acid. So if my body is in an acidic state, well, then I want to get rid of some of that CO2. So I'm going to increase that rate and the depth and blow off the CO2. And it works the other way as well. If I'm alkalotic, or too much of a base, then I'm going to decrease, my body will decrease the respiratory center stimulation, and that's going to cause me to hold on to CO2, or hold on to acid. Therefore, I will become more acidic, or at least balance out my pH. So when you think about the lungs, think about CO2 and consider it as an acid. We can either give it away, or we can hold on to it depending on the body's needs. the lungs can compensate within minutes. And here's a good example. I've mentioned there, with increased deep respirations, your CO2 is eliminated, so your pH will actually elevate. And a good example of this is a patient that hyperventilates. They're breathing really fast, really deep. What they're blowing off is their carbon dioxide or their CO2. So what we want them to do is breathe back in some of that CO2. And that's why it's so effective with somebody who's hyperventilating to have them breathe into maybe a brown bag. So they breathe back in some of the CO2 and they actually fix themselves. Side effects could be tetany, anxiety, dizziness, palpitations. If any of y'all have seen somebody who's hyperventilating, most of them do experience some of those symptoms there. With decreased respirations, your CO2 is kept on board, so our pH will become more acidic. Think about the patient with respiratory failure. They're having trouble ventilating themselves, or maybe they have quit breathing altogether. We may use an ambu bag and hyperventilate them to correct their pH balance. So they've trapped the CO2, they've kept it on board, it's caused a respiratory acidosis, and to fix that we hyperventilate them with the ambu bag to get rid of that CO2. Side effects may include decreased level of consciousness, tachycardia, and of course our brain's going to need some O2 as well. The third mechanism we use to compensate for acid-base imbalance is the kidneys. Kidneys can regulate bicarbonate, that is abbreviated HCO3, by holding onto or releasing it in the renal tubules. So when you think of bicarb, I want you to think of your kidneys. Bicarb is a base. Bicarb, we can let go of it, maybe if the body is too alkalotic. If the body is too acidic, we want to hold on to our bicarb. Well, that can be determined at the kidney level, whether we hold on to or release bicarb to compensate. Please note, for the kidneys to compensate, it does occur over hours to days, so it's not an immediate response. With acidosis, the kidneys are going to excrete hydrogen ions and hold on to the bicarb or the base. And with alkalosis, the kidneys hold on to the hydrogen and we're going to let go or excrete the bicarb, or what we consider the base. So I've talked about three main control mechanisms that we have: the buffers, the lungs, and the kidneys. There's a little bit more about the kidneys that's essentially just clarifying what I just said. All right, let's look at some specific disorders. First one being respiratory acidosis. With respiratory acidosis, the respiratory system fails to eliminate CO2. You may also see this called PaCO2, and what that stands for is the partial pressure in the artery of CO2. That's the reading you're going to get on an arterial blood gas. Don't let that throw you. Just concentrate on, with respiratory acidosis, we have too much CO2, too much carbon dioxide. So our pH, when we look at our pH levels, we're actually going to be acidic. So we'll be less than 7.35. Respirations will be stimulated because the body's going to say, hey, I can fix this. So we're going to speed up our respirations to help blow off some of that acid. But if the lungs cannot fix it by themselves, we've always got the buffers that will help try to neutralize the acidosis, and the kidneys can try to compensate. They'll try to reabsorb bicarb or base to help neutralize that acid. With respiratory alkalosis, we're going to have low levels of CO2 and probably high levels of O2. So if we look at our pH is going to be greater than 7.45, or we're going to be in an alkalotic state. The most common cause for respiratory alkalosis is hyperventilation. we're blowing off all that CO2. And what we need to do is, again, put a bag over their mouth and let them rebreathe that CO2 or let them rebreathe that acid. The body will try to compensate for the respiratory alkalosis by eliminating excess by eliminating excess bicarb through the kidneys. So the lungs will try to compensate, but also the kidneys are going to try to compensate as well by getting rid of base. With metabolic acidosis, we have too many hydrogen ions, or we've lost too many bicarbonate ions. The pH is going to be less than 7.35, and the lungs will try to compensate blowing off CO2, which will increase the pH. Treatment may include sodium bicarb. Patients that are in renal failure often end up in a metabolic acidosis. They're in an acidic state because they can't get rid of waste, can't get rid of acid. So sometimes we have to give them IV sodium bicarb to treat their metabolic acidosis. Also, patients that are in DKA, diabetic ketoacidosis, they are also in a metabolic acidosis. Metabolic alkalosis, on the other hand, is when we have an increase in the bicarbonate or loss of our acid or hydrogen ions. So our pH is going to be greater than 7.45. It may be due to a loss of hydrogen ions that could be caused by prolonged NG tube suctioning, excessive vomiting, diuretics, or maybe even electrolyte disturbances. The thing to keep in mind with, is it respiratory, is it metabolic, that can get confusing. If the lungs are related or there's a disease process involving the lungs, it's probably a respiratory issue. Everything else most likely is going to be a metabolic type issue. Here's a hint when talking about metabolic losses. Anything that the patient loses above the waist, and I'm talking about GI related. So GI loss above the waist, they're going to lose acid. So think about everything that's in the stomach and above to the mouth. If you lose any fluid this way, through vomiting, NG tube, what have you, you're going to be losing acid. Because we lose acid, that means the body's going to be in an alkaline state or a metabolic alkalosis. GI loss below the waist, think about everything below the stomach or below the waistline and down. If you lose below the waist, such as diarrhea, you're losing base. So if you have excessive diarrhea, that's going to cause a metabolic acidosis. So if you can remember those two hints, that will help you. And the way I keep that straight is to always remember, well, you have acid in your stomach, so if you remove what's in the stomach, you're going to have an alkalosis state. All right, when we look at the ABGs, and this takes practice, I don't expect you to have this mastered. I do expect you to have a generalized understanding, though, when looking at ABG values. We already have determined the normal pH should be 7.35 to 7.45, and we know that is our hydrogen ion concentration measurement. The CO2 levels, that's the same thing as the carbon dioxide we've been talking about. When you put a P in front of it, that means that's the partial pressure, and that means this was obtained through usually an ABG reading. So when you see the CO2 or the PCO2, the normal range is 35 to 45. Keep in mind, CO2 is talking about acid, and this is regulated by the lungs. When we see the HCO3, this is the same bicarb we've been talking about. The normal range should be 21 to 28. And this is usually our metabolic regulator, and we're talking about the kidneys. We consider the bicarb a base. And then you'll also have a PO2 value as well. And again, this is the partial pressure of oxygen in the arterial blood. The normal range is 80 to 100. When evaluating ABGs, it can kind of be tricky, but 3 things you need to look at. You're going to get a good idea of what's going on with the patient. Look at the pH, determine if they are acidic, if they're normal, or if they're alkaline. Look at the CO2 levels and look at the bicarb levels. If you can interpret those, you're going to have a pretty good idea of what's up with your patient. We're going to practice. With respiratory conditions, here's another good hint. This is probably the most helpful hint of the whole presentation. With respiratory conditions, the pH and the CO2 go in opposite directions. And you can remember ROME, respiratory opposite, metabolic equal. And what that means, if the pH is elevated and your CO2 is low, then you have a respiratory issue. If your pH is decreased and your CO2 is high, that's another good indicator that you have a respiratory issue. So compare your pH with your CO2, and if they're going in opposite directions, one's high and one's low, it's a respiratory issue. Then you have to look at the pH and determine, well, is this an acidosis or an alkalosis? Another big hint is if the pH is a normal range but other values are abnormal, which sometimes is the case, most likely we have used our mechanisms, whether it be the buffers, the kidneys, or the lungs, to compensate. So you might have a normal pH, but everything else is still out of whack. That means compensation has occurred. So let's practice a couple values here. We're going to start with the top left hand. The pH of 7.12, a CO2 of 49, and an HCO3 or bicarb level of 24. When you think about the values that I gave you, your pH is low, your CO2 is high, and your bicarb is within normal limits. Therefore, the one on the upper left-hand corner is a respiratory acidosis. How do I know it's respiratory? Your CO2 and your pH go opposite directions. One's going up, one's going down. And then when you look at your pH alone, 7.12 is considered acidic. Looking at the upper right hand side, pH of 7.52, we already know that's an alkaline state. We've got a CO2 of 30, so that's low, and our bicarb is normal there as well. Because my 7.52 is elevated and my CO2 is decreased, I know it's a respiratory issue. And because my pH is 7.52, I know it's an alkalosis. So this would be a respiratory alkalosis. Looking at the bottom left-hand side, pH of 7.62, that one's definitely high. My CO2 is within normal limits, but my bicarb this time is elevated. So pH of 7.62, I'm alkaline, and my bicarb is going the same direction. When your bicarb and your pH go the same direction, it's going to be a metabolic issue. So this is a metabolic alkalosis. The bottom right hand side, pH of 7.30, we know that's acidic. My CO2 is within normal limits, and my CO3 is low. So my pH and my CO3 or my bicarb going in the same direction, so they are low. So this is a metabolic acidosis.